Hi, welcome to this learning module on the rehabilitation therapy services you will encounter on the inpatient floors, Zayed 3 West in the NCCU, Zayed 12 East and Zayed 12.
Next, we will discuss the speech-language pathologist's role in the acute care setting. When assessing a patient with suspected dysphagia, speech-language pathologists assess the anatomy and physiology of swallowing, specifically the oral and pharyngeal phases. In order to assess the disordered swallow, you must first understand the normal swallow. There are 3 phases of the swallow: the oral phase, the pharyngeal phase, and the esophageal phase. During the oral phase of swallowing, liquid is maintained in the oral cavity, solid items are masticated, and all material is cleared from the oral cavity into the pharynx. The pharyngeal phase begins at the tongue base, which in a normal swallow is where the swallow is initiated. This allows for rapid passage of bolus material into the digestive tract and protects the airway from aspiration. Additionally, 31 muscles, 6 cranial nerves, and multiple levels of the central nervous system are involved in swallowing. What is the amount of saliva an adult can produce in a day? The answer is 3 pints. If a patient is experiencing difficulty swallowing, they may demonstrate difficulty with the management of his or her secretions. How long in centimeters are the tongue, the pharynx, and the esophagus? The tongue is 10 centimeters long, the pharynx is 12.5 centimeters long, and the esophagus is 25 centimeters. What is the duration in seconds of the oral phase, the pharyngeal phase, and the esophageal phase? The duration of the oral phase is about 1 second. The duration of the pharyngeal phase is also about 1 second, and the duration of the esophageal phase is 10 to 20 seconds. The incidence of dysphagia varies based on the patient's diagnosis. For acute stroke patients, the incidence of dysphagia depends on the location of the lesion. For a unilateral hemisphere lesion, 39 to 40% of patients experience difficulty with swallowing. For a mixed hemisphere lesion, for example, a patient with both right and left hemisphere involvement, 51 to 55% of patients have some type of dysphagia. Patients who have a brainstem lesion have the highest incidence of dysphagia, ranging from 40% to 80%. The large range is likely due to cranial nerve damage or involvement. Dysphagia is also common with neurological and neuromuscular disorders, including ALS, Parkinson's disease, MS, muscular dystrophy, and myasthenia gravis, as well as after cervical spinal surgeries. With the anterior approach of cervical spinal surgeries, the incidence of dysphagia is up to 50%, primarily due to the pharyngeal swelling following surgery. Dysphagia is typically temporary with this population. The incidence of dysphagia is lower with the posterior approach of the cervical spinal surgeries. However, it is still seen in approximately 20% of patients. It is important to identify dysphagia early during the patient's hospital stay because dysphagia that is not managed can result in upper airway obstruction, aspiration pneumonia, dehydration, and death. Additionally, pneumonia and respiratory illness is the leading cause of readmission in stroke patients. By referring patients who are at increased risk of aspiration to speech-language pathology, we can together effectively reduce mortality, reduce the length of stay, and reduce the cost of care. Aspiration pneumonia is the second most common type of hospital-acquired infection in hospitalized patients. In patients who acquire pneumonia from aspiration, there is a 20 to 50% mortality rate. This is more likely with silent aspiration, meaning the patient does not demonstrate overt signs of aspiration during meals, for example, coughing. At Johns Hopkins Hospital, a dysphagia stroke protocol has been put in place. The protocol is used for all acute stroke patients. Each patient receives a 3-ounce swallow screen by a nurse, resident, or doctor who is trained by the speech-language pathologist. This screen is administered in order to identify the patients who are at high risk for aspiration before initiating a diet or administering medication. A physician's order is required for speech-language pathologists to complete a swallowing evaluation. Initially, a clinical bedside swallow evaluation is completed. If additional assessment is required, an objective evaluation of swallowing may be recommended. The gold standard of swallowing evaluations is the video fluoroscopic swallow study, also known as modified barium swallow, also known as cine esophagaryngogram. At Johns Hopkins Hospital, the order is placed as cine with speech. If the patient has undergone a lung transplant, an esophagectomy, has a trach, or is on the vent, the patient will go directly to an objective evaluation. This is due to the high risk of pneumonia if aspiration occurs with lung transplant patients, the concern for a leak with esophagectomy patients, and the high risk of silent aspiration with patients who have a trach and/or require mechanical ventilation. Flexible endoscopic evaluation of swallowing, also known as FEES, is another objective evaluation of swallowing, which is completed primarily in conjunction with ENT. This assessment is not utilized as often, however, is an option for patients who are unable to participate in a modified barium swallow study. This is a video fluoroscopic swallow study of a normal swallow. The oral phase includes retrieving the bolus with adequate lip closure, mastication of solids, and coordinating transfer of the bolus posteriorly into the oral cavity in preparation of propulsion into the pharynx. The pharyngeal phase of swallowing is initiated when the bolus reaches the faucial pillars. Tongue-based retraction, pharyngeal constriction, and velar elevation then occurs. The larynx and hyoid bone elevate and move anteriorly, while the epiglottis deflects to close the laryngeal vestibule. Vocal cord closure should also be noted at this time. During the esophageal phase, the cricopharyngeal sphincter relaxes to allow the bolus to enter into the esophagus, and subsequently closes once the bolus has entered. Peristalsis occurs as the bolus enters into the stomach. After a swallowing evaluation is completed, the speech-language pathologist will make diet recommendations. The physician will then place the order if they are in agreement with the recommendations. Diet recommendations may include regular, soft, mechanical soft, puree, and full liquid diet. However, a full liquid diet is used primarily for patients with esophageal issues or concerns. Liquid recommendations can vary, including thin liquids, nectar-thick liquids, and honey-thick liquids. Additionally, a free text box is available to add special instructions, such as the need for the use of a chin tuck. The speech-language pathologist will also place a pink sign on the patient's door with the recommended diet and swallowing strategies.